Hello, my name is Miss Hahn, and I am going to go over chapter 14 out of our Ricci, Kyle, and Carmen Maternity and Pediatric 5th edition nursing textbook. So, chapter 14 is the nursing management during labor and birth. Our learning objectives include examine the measures used to evaluate maternal status during labor and birth, discuss the advantages and disadvantages of external and internal fetal monitoring, including the appropriate use for each, choose appropriate nursing interventions to address the categories of fetal heart rate patterns, outline the nurse's role in fetal assessment, appraise the various comfort promotion and pain relief strategies used during labor and birth, summarize the assessment data collected upon admission to the perinatal unit, relate the ongoing assessments involved in each stage of labor and birth, analyze the nurse's role throughout the labor and the birth process. So, there certainly is a saying that a baby changes everything. And if you've never heard that, well, today you have. Labor and birth, the whole process is a life-changing event for the birthing person or woman and the family. So, your role as a registered nurse is to be respectful, available, encouraging, supportive, and a professional collaborator throughout the whole process. So, some of the nursing management for labor and birth involves obviously assessment, providing comfort measures and emotional support, providing information and instruction, being their biggest advocate, and being a big support for their partner. So, in this chapter, we're going to explore those key aspects of nursing management during labor and birth and your role as a professional registered nurse during each step and stage of labor and birth. So, during labor, there are different techniques to use to assess maternal status. Those techniques provide an ongoing source of data to determine the client's response and progress in labor. So, when we assess the maternal status, we're looking at the vital signs. That includes temperature, blood pressure, pulse, respiratory rate, and pain, and oxygen saturation. Um, and we're also going to look through their prenatal record, and there's going to be some of that information that needs to be input on the electronic health record. And we need to be able to look at that prenatal record through that review and identify any risk factors that could possibly contribute to a decrease in uteroplacental circulation during labor, or maybe a dystocia or anything like that. So, next, a vaginal examination. When we do a vaginal examination, we are checking cervical dilation, so how open the cervix is, effacement, how thinned out the cervix is, the amniotic membrane status. So is it ruptured and was that spontaneous on its own or artificial done by the provider? Or is it intact? What is the fetal descent and presentation? So we need to know all of this and monitor that periodically to identify labor progress. So we don't want to do sterile vaginal exams all the time. We limit that to just when it's needed, so that we're not introducing lots of bacteria and things up into the cervix, which can get inside there with the baby. Now, when the client does have rupture of membranes or her amniotic sac ruptures, then the first thing we are going to do is assess the fetal heart rate. That is a big thing. That's a huge answer to a lot of questions on your prioritization on what do you do first. So, anytime the membranes rupture, whether it's spontaneous or artificial, we assess the fetal heart rate first. And then we look at the amount and the color of the amniotic fluid and take note if it has any odor. Um, Uterine contractions are next. We monitor those. If we're doing external monitoring, we will palpate the abdomen. Um, Also, if she is ruptured and she needs internal monitors, then we will use an intrauterine pressure monitor, which actually gives us the exact strength of the contraction. Now, Leopold's maneuvers, that helps the nurse to determine the presentation, position, and the lie of the fetus. So you actually have in your book pictures that show you how to do this and describe how to do this. And so this is the maneuvers for Leopold's maneuver. In maneuver one, we're trying to figure out what's the fetal part. Is it the head or the buttocks? That's located in the fundus or the top of the uterus. With maneuver two, we are going to figure out which maternal side is the fetal back located on. Maneuver three is going to help us figure out what the presenting part is that's presenting down towards the cervix. And maneuver number four is going to help us figure out is the fetal head flexed and engaged in the pelvis or not. So as a nurse in the specialty, you would definitely get to practice this. Let's have a knowledge check real quick. The nurse is caring for a patient in active labor. The nurse notices the fetal heart rate begins to decrease with the increment of the uterine contraction from its baseline of 135 beats per minute to 115 beats per minute. The fetal heart rate waveform on the external fetal monitor is also noted by the nurse to reflect the shape of the contraction. How should the nurse interpret this finding? Would it be A, late deceleration, B, early deceleration, C, variable deceleration, D, fetal bradycardia? Now, listen, I'm going to refer you to get your whiteboard out and your dry erase marker and draw this out, okay? And remember, veal chop mine, what we went over. So when you draw this out, the things that we're going to draw out is we're going to draw a uterine contraction on the bottom, and we are going to draw above that the fetal heart rate. And so we've got to look at when the fetal heart rate starts to decrease in order to understand what we're looking at. So you already know by the question stem that the fetal heart rate tracing reflects, that deceleration reflects the shape of the contraction. So it looks similar to the contraction, or it's like a mirror image almost. But what we've got to know is where does it start to go down? At the beginning of the contraction, the middle of the contraction, those things. So, in knowing what you already know, you should be able to automatically discard C and D. The reason why is because variable decelerations do not reflect the shape of the contraction. They are either a abrupt V, W, or U pattern, but it's not going to reflect the shape of the contraction, okay? And they can happen without a contraction. Fetal bradycardia, that means that the fetal heart rate goes below 110 beats per minute. Nowhere in that question stem does it say that it decreased below 110 beats per minute for the fetal heart rate. It dropped to 115 at its lowest point. So now we're left with A and B. So here's where I'm going to tell you, go with your gut, your instinct. So the correct answer is early deceleration. So early decelerations are visibly apparent by a gradual decrease of at least 15 beats per minute or more by greater than or equal to 15 seconds, in which the lowest point of the fetal heart rate occurs at the highest point or peak of the contraction. So the lowest point of the fetal heart rate is the nadir, and the highest point of the contraction is the acme or peak. Okay. So the increment of the contraction is the start of the contraction. The decrement of the contraction is the end of the contraction. So those are terms you're going to want to understand in regards to contractions so that you can discern what you're looking at on a fetal heart rate monitor. So late decelerations, they visually, it's very visually apparent that they decrease in the fetal heart rate, but it occurs, the decrease starts at or after the peak or acme of the contraction. And the fetal heart rate doesn't come back to its baseline fetal heart rate until after the contraction is over. Okay. So it's off center. The nadir is not centered with the acme or peak of the contraction. It's off centered. It's not an exact mirror image like an early deceleration. And an early deceleration is head compression, by the way. Okay, so for our fetal assessment during labor and birth, that's one of the primary evaluation tools to determine the fetal oxygenation status and well-being. So in order to determine that, we are looking at the fetal heart rate. Fetal heart rate assessment, depending on what's going on with the client, can be done intermittently or it can be done continuously. We can use a Doppler ultrasound device or an electronic fetal monitor device where you use either an external or an internal monitor part. But the object of fetal heart rate monitoring is to reduce the mortality, morbidity by ensuring that all fetal hypoxic insults are identified in time to allow the removal or alteration of the reason for it, or to ensure a safe birth of our fetus before there's irreversible asphyxia damage. So other things we look at, the amniotic fluid analysis, it should be clear. You could see green amniotic fluid if a meconium bowel movement has occurred in utero from the fetus. If it's foul smelling, we might suspect an infection, but it should be clear. It usually doesn't have much of an odor, if any odor at all, that's detectable. So that would be what we're looking for. Now, fetal heart rate patterns, we need to be looking at the fetal heart rate baseline. We need to look at the baseline variability, and we need to be looking for any periodic or episodic changes. So in your book, what that means, so you're going to be looking at page 424 and 425, and all the way through 427. So this is looking at what baseline fetal heart rate means, and that's over a 10-minute segment, minus any kind of accelerations or decelerations. And it should be between 110 and 160 beats per minute. That's what's a normal fetal heart rate. Bradycardia is below 110 beats per minute. Tachycardia is above 160 beats per minute. Now, when we're looking at baseline variability, that is those irregular fluctuations in the baseline fetal heart rate. It's measured as the amplitude of the peak to trough in the beats per minute. And so we categorize that as absent or undetectable. If we see fluctuation range observed at fewer than 5 beats per minute, that's minimal variability. Fluctuation ranges from 6 to 25 beats per minute is moderate variability, which is very reassuring and normal. And fluctuation ranges more than 25 beats per minute is marked variability. So you have examples on page 425, figure 14.7 to look at. Now, periodic baseline changes, those include accelerations and decelerations. So an acceleration is a transitory increase in the fetal heart rate above the baseline that lasts less than 30 seconds from onset to peak. And it lets us know that if we're seeing a fetal heart rate that elevates more than 15 beats per minute above the baseline, lasting longer than 15 seconds, but less than 2 minutes, if we see that, that is very reassuring. That's good to know. That lets us know that with a good moderate variability, a normal fetal heart rate baseline between 110 and 160, and seeing accelerations present in the heart rate is a reactive, normal fetal heart rate. Now, a deceleration is a fall in the fetal heart rate, and it could be due to various things. That's where VIL-CHOP-MIND comes in, the acronyms, or mnemonics. So we have variable decelerations, early decelerations, and late decelerations. So your variable decelerations, those are your decelerations or decreases in the fetal heart rate that are abrupt. They go down really quick from the fetal heart rate baseline down to the lowest point or the nadir of the fetal heart rate. And they go back up relatively quickly as well to the baseline fetal heart rate. Oftentimes we'll see them have little shoulders or looks like they might start an acceleration before an abrupt drop. And they're typically shaped like a V, W, or U, a sharp U. Now, the reason why we have variable decelerations in the fetal heart rate is due to cord compression. And variable decelerations can occur during contractions or at any point between contractions. So all we do for that is we reposition the mother and keep an eye on it. Now, early decelerations, that goes back to that question that we had for the knowledge check just a moment ago. And I've already told you what they mean, head compression. So the baby's head is engaged and getting squished in the birth canal. So when we see early deceleration signifying head compression, we want to identify the labor progress and see kind of where we're at. Late decelerations. Now, I described that as well already, but when you see a late deceleration, I want you to automatically think placental insufficiency. The placenta cannot get enough oxygen to the fetus from the mother for whatever reason. And so the fetus reacts by having a late deceleration. It's that off center deceleration. So, what do we do for that? Well, we have to execute interventions quickly, meaning we do intrauterine resuscitation techniques. And so that's where box 14.1 on page 427 comes into play. And we'll look over that in a moment. So, guidelines for assessing fetal heart rate. We know that the fetal heart rate monitoring has direct correlation to fetal well being. We've already talked about intermittent versus continuous, external versus internal. And in the hospital setting, depending on what's going on, it is very common to have continuous electronic fetal monitoring, whether it is with wired monitors or wireless monitors. So, as soon as a client comes to the labor and delivery unit, we need to get an initial 10 to 20 minute continuous fetal heart rate assessment so that we can get the baseline heart rate, see what the variability is, and see if there's any periodic changes like accelerations or decelerations, and also monitor the contractions. We also need to complete a prenatal and labor risk assessment on all of our clients. If we have a low risk laboring woman, the doctor may, or the nurse midwife may, order intermittent fetal monitoring auscultation every 30 minutes. And for high risk women, every 15 minutes. Most of the time, though, when you in the hospital setting, when you see for high risk women, it's continuous fetal monitoring, though. Now, during the second stage of labor, remember that's the stage where we are pushing and delivering our baby. Our fetal monitoring, we should be doing intermittent auscultation of the fetal heart rate every 15 minutes for a low risk woman, every 5 minutes for high risk. High risk can include oxytocin use, okay? So you're going to be documenting every 5 minutes if it's continuous fetal monitoring. So again, the primary objective of external fetal monitoring, or just fetal monitoring in general, is to provide information about fetal oxygenation and prevent fetal injury due to impaired fetal oxygenation during labor. So the purpose, we need to detect any fetal heart rate changes early before they are prolonged and profound and could cause any irreversible injury from fetal hypoxia or even death. Now, electronic fetal monitoring did increase when it was introduced. The cesarean section rate. However, we still generally have good outcomes. It just does impact the hospital, their scoring when it comes to looking at those different statistics. So this is the interpreting fetal heart rate patterns, or the fetal heart rate categories that you need to review. And you can find this on page 427. Actually, it's 424. I don't know why I put 427, but it is table 14.1. So category 1 is considered a normal predictor of normal fetal acid base status and doesn't require any intervention. It's just normal. All the fetal heart rate pattern, it looks good. It's reactive and reassuring. And it has the criteria in the bullet points. Category 2 is indeterminate. So we can't predict whether it's normal or abnormal fetal acid base status, but we do need to evaluate and continue to survey, just continue to monitor that, continued surveillance. So it's going to have different criteria than category 1. This is where we may have some fetal tachycardia or bradycardia present, but the bradycardia has variability. It's not accompanied by absent variability. Now, the baby can have absent baseline variability, but as long as it doesn't have recurrent decelerations of any kind. We also can have minimal or moderate or marked variability, recurrent late decelerations with moderate baseline variability, recurrent variable decelerations with minimal or moderate baseline variability, overshoots or shoulders, and prolonged deceleration greater than 2 minutes but less than 10 minutes. So indeterminate, we're going to do a few things to help her out, like, for instance, turn her on her side or just reposition change. Simple things like that. But when we look at category 3 is abnormal. Category 3 lets us know that it's an absolute predictor of abnormal fetal acid base status, and we have to perform interventions. So these are our recurrent variable decelerations with declining or absent variability, recurrent late decelerations, fetal bradycardia, sinusoidal pattern, that smooth undulating baseline, that requires immediate intervention. So those intrauterine resuscitation techniques and potentially expediting a delivery. So you do need to know that. So category 3, we want to do those interventions or even expedite a delivery in order to prevent poor outcomes for the fetus. So we're going to reposition the mother, so maybe on her side or knee chest. We're going to turn off Pitocin if she has it going. We are going to give an IV fluid bolus of her primary IV solution, which is usually lactated Ringer's or normal saline. We're going to give her oxygen with a non-rebreather mask cranked all the way up to 10 liters for oxygen. We are going to possibly check that cervix. We're going to call a provider and let them know what we see, what's going on, what we did. And we're going to be ready to expedite delivery, meaning we may need to get the operating room ready, and we may need, depending on what her dilation is, we may need to have a delivery table ready with potentially having forceps or a vacuum extractor ready in case it's needed. So internal monitoring. There's specific criteria that has to be met in order for internal monitoring to be used. Number 1, whether it's a fetal scalp electrode or an intrauterine pressure catheter, the amniotic membranes must be ruptured. Number 2, cervical dilation needs to be at least 2 centimeters. We got to get our fingers in there to adequately work. Number 3, the presenting part of the fetus needs to be low enough to allow placement of the fetal scalp electrode on. And number 4, a skilled, trained practitioner available needs to be the one inserting the FSE or the IUPC, period. Okay? Sometimes the nurses are tested out and signed off and can do it if the provider requests it. Other times, facilities say providers only, so the provider would be required to come in. So here's where I was talking earlier about the four categories of baseline variability: absent, minimal, moderate, and marked. And looking at page 425, figure 14.7 to look at those. So, one thing I want you to realize is that absent and minimal variability that can occur even if the baby's, especially if it's a short amount of time, that can occur just because of a fetal sleep cycle. And then it should go back to moderate. But it could also be due to hypoxia and things like that. Now, marked variability, whether it's absent variability or marked variability, a fetus cannot endure long periods of time with either of those. But marked variability means take action now. Prolonged absent variability, take action now. Marked variability, we can't tell what the fetal heart rate baseline is, the baseline heart rate. It's not clear at all. And that's concerning. Here's where you see the decelerations. Now, this used to be in the old book. However, your figure 14.8 on page 426 just shows you the fetal monitor strips. So I left this in here showing you where A for early decelerations shows you that head compression's occurring. B for variable decelerations reminds you this picture that the cord's being compressed. C for late deceleration reminds you that there's something wrong with the placenta. It's not allowing enough oxygen to come from mom to baby. Okay? So that's why I left this old figure in here, but with a reminder to see your book, to see the monitor strips. Here is the interventions for a category 3 fetal heart rate. So notify the healthcare provider and obtain further orders. Discontinue oxytocin or other uterotonic agent. Turn the client to left or right lateral, knee, chest, hands and knees. Anything to increase placental perfusion or relieve cord compression. Administer oxygen via non-rebreather face mask to be able to give the fetus more oxygen. Increase the IV fluid rate to improve intravascular volume and correct any maternal hypotension, like if it occurred because of an epidural that was recently placed. Assess the client for any underlying contributing causes. Provide reassurance that interventions are to affect pattern change for the fetus. If you are pushing, modify pushing in that second stage to improve fetal oxygenation. Document any and all interventions and any changes in fetal heart rate patterns. Prepare to expedite delivery via surgical birth if the pattern's not corrected in 30 minutes. Please remember that. Comfort and pain management. So that starts on page 427 through 439. So we know pain is a universal experience and the intensity is highly variable from client to client. And as a nurse, we're in the ideal position to provide our childbearing clients with balanced, clear, concise information about effective non-pharmacologic and pharmacologic measures to relieve pain. So you must be knowledgeable about the most recent scientific research on labor pain relief modalities to make sure that you're giving accurate and unbiased information about effective pain relief measures available to the client. That way, the client can determine what she would like and help her determine what's an acceptable pain level for her. Also, allow her a choice of pain relief measure. So we are mandated to assess pain for all clients. Sometimes clients will come in the labor and delivery unit with a birth plan saying they don't want to be asked about pain. So what the way you can handle that is say, I will respect your wishes, but occasionally I do have to ask your pain scale just a number. I'm not going to try to coerce you to take anything for pain. You have to ask for that yourself. I won't mention it. Non-pharmacological pain measures and management. Um, Education and evaluation of effectiveness are key concepts when we implement these measures for pain. It includes continuous labor support by the support person and the nurse. Hydrotherapy may be able to be done whether it's in the shower or maybe in a tub. Ambulation and position changes are huge. Keeping the client off of her back, if at all possible, is important. Any supine position is not good. Sometimes acupuncture and acupressure may be used by the client. Attention focusing and imagery, therapeutic touch, massage, and effleurage may be done. Effleurage is where the support person will just gently stroke over the abdomen in coordination with the client's breathing through the contraction, and of course, breathing techniques. So, pattern paced breathing is an example of that. Pharmacologic pain relief during labor includes systemic analgesia and regional or local anesthesia. So, systemic and analgesia, what I want you to remember is while giving IV pain medication is still done, it's still not as popular as your epidural or going natural or some hospitals that have nitrous oxide. So we have neuraxial analgesia, which basically is your epidural intrathecal medication that gets placed there to relieve pain. It is said not to interfere with the progress or outcome of labor. Now, labor nurses may argue with you on that one. There's no need to withhold epidural analgesia until the active stage of labor. And so they also have changed medications and techniques so that the client become more active in labor by being able to feel the pressure versus pain. So that's a big difference compared to many years ago when they were just completely numb and struggled with pushing. So our systemic analgesia is typically administered parenterally through your existing IV line. So it could be opioids, but those cross the placenta. It could be antiemetics like hydroxyzine, and those can cause sedation, or even benzodiazepines that give us sedation or amnesia effect, like midazolam or diazepam. But the one thing I want you to remember is with systemic analgesia, if it's administered within 4 hours of the delivery of the fetus, then the nursing team needs to be prepared to potentially care for a neonate who has some respiratory depression to some extent. So having naloxone or Narcan for the fetus or the neonate on hand just in case that occurs is important. Regional anesthesia, we have epidural block, combined spinal epidural block, patient-controlled epidural, local infiltration. So that's like if they put the lidocaine in for an episiotomy or laceration repair. Pudendal block, usually they'll do that for the second stage or an episiotomy or an operative vaginal birth. And they're really going in deep putting in the numbing medication. And then intrathecal, which is spinal, which is like what we use for our cesarean deliveries. So you need to understand that. Now, for general anesthesia, that's typically reserved for emergency cesarean birth or a client who has a contraindication to the use of regional anesthesia, which does occur. Now, they can use IV injection, inhalation, or both. They may use thiopental or propofol to produce unconsciousness, then a muscle relaxant, then intubation, followed by administration of nitrous oxide and oxygen. So these clients get anywhere from 30 minutes to an hour of really deep sleep. And then when it's all over, said and done, we wake them up in recovery and do lots of good monitoring. Now, as far as the stages of labor, you need to absolutely understand and know the different stages and phases and how they're managed. So again, in the first stage of labor, we may start out in triage where we're trying to determine if they're even in labor. We're going to get their estimated due date or date of birth for the fetus, check on fetal movement and how often they're feeling it in the past few days, check for any premonitory signs of labor they're experiencing. We need to know their parity, gravida, previous childbirth experiences, time frame of previous labors, what's the characteristics of their contractions. Lay a hand on that abdomen and palpate so you can tell the strength of it. Is there any bloody show present? What's the membrane status for the amniotic membranes? And then does the client have support present or is the client alone? So these are all important things to look at. Now, when we're admitting a client in that first stage of labor, we are getting a thorough health history that not only includes health history for the mother, but a surgical history, a family history, a genetic history, all of that. We're doing a good physical assessment, a head to toe assessment, and getting that height and weight. Now, a lot of times we can look at the prenatal record and verify with the mother what their height and weight is without actually physically doing one, unless they have a problem that requires us to repeat a weight. We may get a fundal height measurement if the client's under 36 weeks gestation, but more than 20 weeks or at 20 weeks. Check on uterine activity, like contraction frequency, duration, and intensity. Again, membrane status, what's her dilation and effacement, and station of the presenting part. What's the fetal heart rate, the fetus position and station, pain level for the client, all the fetal assessments, lab studies. Usually we'll get a urinalysis and a complete blood count, and a type and screen for the client's blood type. If the client hasn't had any kind of prenatal care whatsoever, and this is the first time they're coming in is when they're in labor, they're going to get the whole workup that they would have gotten on their first prenatal visit. That includes all of the STIs, group B strep, potentially, all of that. And then assess that psychological status. We're also going to be getting our vital signs, checking the fetal heart rate for fetal well-being throughout that first stage of labor, vaginal examination by a skilled provider, so that would be the nurse or the client's provider. Uterine contractions again, behavioral, psychological, what's their pain level, how are they coping? But we're doing this all the way through. What's her knowledge about what's going on, her experience, and her expectations. That's important to understand as well. And remember, the first stage is the latent phase, which is 0 to 6 centimeters, and the active phase is 6 to 10 centimeters. Okay. We used to have latent, active, and transition, but we just have two phases instead of three. The second stage of labor, um, we know that typical signs of this second stage for the client includes an increase in apprehension or irritability. If she's not already ruptured, spontaneous rupture of membranes may occur. She may suddenly start sweating, especially right around the upper lip, the face. She may have an increase in bloody show. Low grunting sounds from her, complaints of rectal and perineal pressure, and she may even begin to involuntarily bear down and push. We're going to be doing vital signs still, including a temperature check, pain level, oxygen saturation, all those things. Monitor her contractions, the fetal heart rate, amniotic fluid, and coping status. It's not only of her, but of whoever's her support person or people. And assessments wise, we need to know the progress of labor. So we might look as we're getting ready to do a sterile vaginal exam or SVE and know, is the perineum bulging? Is there separation of the labia? Is there advancing and retreating of the newborn's head during and between bearing down efforts, or even crowning where the fetal head is visible at the vaginal opening? And of course, that vaginal exam is to help determine, you know, is it an appropriate time for her to push? And we need to let the provider know. So there's a lot of things we do to support the client and their support person while they are having their baby, before birth and after birth. We want them to be active decision makers, not passive. We want to support following their urge to push and not us having to tell them. So encourage no pushing until they have a strong desire or until we know the descent of the fetal head is at a good spot. Provide lots of instruction, assistance, and pain relief where needed, even if it's non-pharmacologic pain relief. Change positions to help with fetal head descent and reduce pain. And of course, prepare to assist with delivery. After birth, you're going to be cleaning the perineal area and the vulva, assisting with the birth process by suctioning the newborn, maybe even getting an APGAR score, umbilical cord clamping if needed, drying, suctioning the newborn right at birth, placing the baby skin to skin with warm blankets over it for thermal regulation, or assessing if the baby is not well enough to do skin to skin yet and going straight over to the radiant warmer. Putting on those identification bracelets on the baby and the client, and the one person the client chooses to have the fourth bracelet. So all of those are important. Now, in the third stage, while we're doing immediate newborn care and assessment, but during this time, the placenta starts to separate and begins to be delivered. So, we also have to be aware of potential perineal trauma, episiotomy, or lacerations that may have occurred during the delivery process. So that's important as part of our assessment. And then, of course, examining the placenta and fetal membranes to ensure everything is there. The provider is supposed to do that and verify, and you can do that as well and verify before you package that placenta to be sent to the lab or whatever the facility does with it. So, signs of placental separation, the uterus starts to contract firmly. The uterus changes in shape to a globular shape. There's a sudden gush of blood from the vagina. And as the placenta pulls away, the umbilical cord appears to lengthen and protrude more from the vagina. So sometimes the provider may instruct the client to push when separation is apparent, but they should never be pulling and tugging on the cord to try to deliver the placenta. They may hold just some slight traction so they can, while they're looking at things and talking or whatever they're doing, they can feel when that placenta is starting to um, pull away because of the slack that occurs in the umbilical cord. They will oftentimes order for the nurse to start oxytocin once the placenta is delivered. And we need to assist the client in a comfortable position. Give her warm blankets, especially if she's shaking. She's not usually shaking because she's cold. It's usually due to the birth process. And if she's had a vaginal delivery, we're typically, when we're doing perineal care, we're applying an ice pack to the perineum. Explaining all the different assessments that's coming, including the fundal check and the bleeding check, and monitoring her physical status, and documenting all the birth statistics on the electronic documentation system, as well as in the birth book that most labor and deliveries keep. In the fourth stage, this is where the client is recovering and the neonate is transitioning. This is usually the first 1 to 4 hours after birth. We're going to be doing on the client vital signs, fundal checks, bleeding checks, perineal area checks, check her comfort level. What's her lochia look like? How much is it? Are the clots present? What's her bladder status? Intervention wise, provide lots of support, education, information. We're going to do lots of hygiene care, changing her pads, weighing those pads. If her bladder appears to be full, we need to have her void, or we may have to straight catheterize her. Provide comfort measures, promote bonding and attachment between her and the newborn, maybe even assist in breastfeeding. And of course, again, education, education, education. And of course, I can't say enough of the fact that you are in a wonderful position and a powerful role in the labor and the birth process. You're the collaborator in that miracle of birth of a neonate in the family. And the focus that you will have is supporting, protecting, advocating, empowering, and educating the client and her family during the most vulnerable times, which is while she's laboring and delivering. So this concludes chapter 14. Thanks for hanging with me. Have a great rest of your day.